So one of the most common procedures that we do is a coronary intervention that involves patients who have atherosclerotic disease that is deemed severe by any modality. So that may be by stress testing if the patient is an outpatient, or by clinical factors reporting chest pain, or what we term as typical angina, chest pain that is typical or occurs with exertion that's relieved with rest, or emotional stress that's relieved with removal of that stressor, or patients who have an abnormal stress test as a result of being evaluated for these type of symptoms. As if a patient is evaluated by me or one of my colleagues on an outpatient basis, we would think about whether the patient is appropriate to undergo a invasive coronary angiogram. That involves bringing the patient to the cardiac catheterization lab on an outpatient basis and inserting a catheter via one of two principal techniques and anatomical locations. The default approach is through the radial artery, which is here, right near the wrist. So a catheter is taken into the heart, and the arteries are found, and they are injected with iodine-based contrast dye, and an X-ray picture is taken like a video clip, and we see the flow of that through opacification of the X-ray iodine-based contrast dye medium that we use. The idea is to create a picture or skeleton of how that artery looks, and we can see through that whether there are narrowings within the heart arteries that may need to be addressed based on the severity that we deem that we're seeing visually. So the blockage is evaluated by whoever's doing the procedure. Sometimes it's very obvious that's a very critical blockage that needs to be addressed by endovascular means, and one means is typically what that means is advancing a different catheter that is capable of doing an intervention, advancing a wire across the lesion to cross that area, then proceeding with a balloon to sort of inflate that area and make some room to do things that we may need there afterwards. One is potentially advancing an ultrasonic camera inside the artery to look at the vessel size, as well as the amount of plaque, what the characterization of the plaque is, quantify the amount of calcium, and then decide whether any further interventions need to be done before we put a stent in. Once we deem whatever we need to be done about that particular lesion is complete, then we proceed with putting in a stent, to a metal sort of mesh-like device to pop open and keep that area that was blocked open for as long as possible for the patient. So that's if the lesion or blockage is deemed to be critically severe just by picture alone. But if it's not significant based on certain values, we may defer intervention and just continue medical therapy for the patient without needing to proceed with a stent implantation. Usually the whole process pre-op, meaning prior to the procedure, takes about an hour and a half to get everything ready. Then the actual taking of the pictures, depending on how, give or take, the amount of difficulty of the anatomy, is usually 20 to 30 minutes. If an intervention needs to be performed, such as placing a stent or some of the other things that I mentioned, such as interrogating the blockage with pressure wire, etc., that may take an hour more or so, depending upon the level of complexity that the blockage needs. More often than not, I would say about 95% of the time, we send the patients home the same day, meaning they don't need to stay in the hospital if all goes well during the procedure, they're feeling well post-procedure, there's nothing to monitor the patient for afterwards, and they feel safe, the patient and family member feel safe and comfortable going home. The typical recovery time after a procedure like this is, if we go through the wrist artery, they wear a band on their wrist and that's taken off prior to going home. Once they arrive at home, we usually say nothing lifting anything heavier than 5 pounds with that hand for about 48 hours after the procedure. Usually we prefer that someone be at home with them for this time, just to make sure that, especially if a patient lives at home alone, it's good to have another set of eyes just to make sure that there is no complication or the patient has any issue post-procedurally. After that first 48 hours, typically the patient can resume normal activity with that particular hand, typically the right hand, but no heavy lifting, meaning especially if a patient is a weightlifter or works in a field of work, line of work that involves carrying very heavy objects, greater than 30 to 50 pounds, we would wait at least 10 to 14 days before advising that a patient go back to lifting anything significantly heavier. Most patients, we advise and highly encourage them to start cardiac rehab, especially for patients who undergo a stent procedure. This is sort of a reassuring program to help patients begin their physical activity in a monitored setting where they hook up telemetry leads to a patient, they start exercising with a monitored technician or a nurse watching them. It's typically a 12-week program, 3 times a week. And as they progress along the program, the intensity of the functional exercises that they do increases. And we sort of look at this as a nice way to get the patient back to their full exercise capability afterwards. So anytime we evaluate a patient who potentially is going to undergo this procedure, we always talk about the risks and benefits as part of the consent process. For a coronary procedure that we reviewed today, typically the risk is low, but we always discuss that the risk of having a stroke or heart attack during the procedure is on the order of less than 0.5%, depending upon the complexity of the procedure. Overall, as a system here at WVU, we're a very high volume center that does a lot of coronary interventions. Amongst our colleagues, all of us do these procedures on a routine daily basis, and we see them very frequently here. On an average day, we're doing about 15 to 20 at least at our main center here in Morgantown. And so I would say we're very familiar and see this procedure extremely often on a daily, hourly basis. By having a higher volume, we do a lot of procedures, and so we're comfortable with taking on very complex coronary anatomies that patients present to us. So I would say overall, the risk is if we deem the patient is a candidate for the procedure, we've already made that decision in their mind that the risk of the procedure does not outweigh the potential benefit.